Yeah. Hi everyone. So people are still coming. So I'm just chatting up with you. I'm going to repeat all this again. Hello everyone. You can smile a little bit. The exam is still a week away. You don't have to be so tensed. You are all theory passed. You should not forget that. Okay. This is not something which is different than what you have already done. Only the format has changed. Now somebody is going to speak to you while you are giving your exam. And in your theory exams there was just a screen on which there were some questions. All right, so don't feel that this is any different from what you have already done for 4 full days, for which you have prepared for the longest of your time. From the last 2 3 months this has been on your mind, and then in the last month and a half of your DNB you have given it a push. And I know you feel that you are disconnected from the text and disconnected from everything. But trust me, you are not. Because once you have passed your theory, that proves that you are actually in a state where you have done a lot of things right. Because it is not easy to clear DNB theory exam. The biggest hurdle in DNB is not the practical, it is the theory. So once you have cleared the theory, then I really don't think any of you should have any sort of thought in your mind that I won't be able to do this or I won't be able to do that, and what is going to be the situation. Only thing is that there is an element of uncertainty because you have previous 5 6 10 years of paper with you, so you know what kind of questions are being asked. And when there you are writing the answers, then you feel nobody is looking at you. Although the examiner, when he reads your answers, then he very well knows what you are doing. So only thing that changes is the fact that there is nobody, there is somebody watching you, and that creates a lot of anxiety. So I'm going to start with the discussion, or I'll wait for 2 more minutes because we are in India and we have to come 5 minutes late, irrespective of what the time is. So I'm going to wait for 2 minutes more. And this is not a academic session. I am not going to tell you what to read, what not to read. We have discussed in detail about these things. I have a YouTube video also. I'll just put up the link of that YouTube video. Just a second. So that anybody who wants, they can just simply go through that video. But although that is not something that, I would want you to worry in the last few days of your exam. If there are any questions that you specifically have in your mind, then I would actually prefer you to ask me those questions before I actually start the session, so that I can structure the session in a way that your uh, yeah. So this is the link to the YouTube video where I have discussed the strategy for practicals in a very detailed manner. So if there are any questions, then I'm all yours. And I'm sure there are a lot of questions, and the questions need not be academic. It could be anything. Whatever is going on in your mind, just say it. No problem. No questions. OSCE sample papers. Whatever I have, I will provide it to you. But I'm going to give you a very structured approach to OSCE, and I know you are pretty much tensed about OSCE only. So I'm going to talk about OSCE in detail, and I'm going to make sure that a lot of your anxiety about OSCE is lessened after this session is over. All right. We have people who are still coming. All right. So I'll start now. So, good evening, everyone. I'm Dr. Anshul Diwakar. I'm your faculty of anesthesia. Now, here we are today. We have come not for discussing anything academic, but I will discuss something that is something that I've been doing for the longest of time. I have always done exceedingly well in my practical exams, the part of the exam where you have to interact with the examiner, despite of not being the best student. So the catch is not that I have been a good student and that is why I've done good in vivas. It is because I have always tried to understand uh, what is that you need in a viva to pass the viva. And trust me, uh, yes. So I'm looking at your questions and I'm going to answer them during the course of this conversation. So don't think that you need the entirety of knowledge to be able to do well in practicals. Practicals is a lot about being practical. So there are certain undertones in the anesthesia practical that you have to remember that there are two parts to your exam now. I was the lucky one who gave anesthesia DNB exam when there were no OSCEs. So there was only one standard practical that we gave in final year. So it is just like that only. And I gave two vivas because one for diploma and one for DNB. So you have to first understand the format of your exam, and the format of your exam is pretty much that you have two parts. One is the OSCE, another is the viva, isn't it? One is OSCE, another is viva. Now, OSCE is something which makes you more anxious, but it is actually something which I would consider as the easy part of the exam because everything is in your control. Everything is in your control. Just a minute, okay? Now, so there are two parts. I'm sorry for that call. You can ignore anyone in this world, but you can't ignore your wife. Ultimately, I have to go back to her only. So, yeah. So there are two parts to your exam: OSCE and the viva, right? And see the questions that have come. The first question by Shivani was provide OSCE sample papers that I'm going to do. But apart from that, sir, history taking format for child case, obs care, do we need to study statistics? Do we need to do systemic examination in detail while taking cases? So all the questions that you are asking me are based on your apprehension about the viva part, isn't it? But let's first understand the structure of your exam. Your exam, the practical exam, is of 300 marks, out of which you have two divisions. One is the OSCE, another is the viva. Now, OSCE is 100 marks and your viva is 200 marks. Am I right? OSCE is 100 and your viva is 200. I'm just admitting them. Yeah. So OSCE is 100. Now, you are more concerned about the viva part because you feel that viva is something that is carrying the bulk of the weightage, that is the 2/3 weightage. Out of 300, 200 is the weightage of the viva. And you consider OSCE as okay because you are like, acha, we'll see what happens. But try to understand this perspective. OSCE is just like your theory exam. There is no difference between your theory exam and your OSCE, isn't it? You are asked 10 questions in theory, 3 hours. You are asked 20 stations in OSCE, 80 minutes. 4 minutes per station. All right. In your theory, they give you a clinical picture or they give you an image or they give you a question and there are sub parts to the question. Every part plays a role. Every part has a particular marking. So even if you don't know the entire answer, still you will be able to score some marks from whatever you know. So that is the second part. So OSCE is just a theory exam for 80 minutes again. So remember, OSCE is by far the most important thing for you for your practical exams. If you are cool, calm, composed in your OSCEs, then your job is done. You have cleared the practicals. I am going to share some sample papers from whatever I have got from here and there. And I've gone through almost all OSCE sample papers which are there. And one thing I'm sure is whatever you have read for your theory exam, everything is asked in your OSCE. The general consensus is very, very simple. There will always be one ECG. There would be one X-ray. Either it would be a chest X-ray. Most of the time, it would be a chest X-ray, or it would be a neonate with the chest and abdomen X-ray. There would be one block, or there would be one USG image. There would be one question from POCUS, which would be very basic because we discuss only basic questions in POCUS. Anesthetic management of all conditions are asked, whether it is renal transplant, whether it is tracheoesophageal fistula, congenital diaphragmatic hernia, severe PIH, criteria, GDM, anemia, cardiac case, mitral stenosis, ischemic heart disease, cardiac protection, RCRI, all the things that you have read in detail in your theory exam, all the things are asked with a case scenario: COPD, asthma, bronchospasm, shark fin appearance, capnography, pulse oximetry, non-invasive cardiac output monitors, all the things that you have already read in detail for your DNB theory exam are commonly asked. Then one question would always be there from airway, again something that you are going to read again and again and again just before your exams, because it is a very important part of your table. Then there would be one question of PSM. So somebody asked me, sir, do we need to read stats? Yes. Do you need to read PSM? Yes. Do you need to read biomedical waste management? Yes. Do you need to read disinfection and sterilization? Yes. Why? Not because there is a question, because that is the part that if you have not read, you won't be able to answer anything from it. So try to understand. In anesthesia, what will go wrong? Suppose you're sitting in front of the examiner. Forget about OSCE. If you're sitting in front of the examiner and they ask you anesthetic management of severe PIH, what wrong will you do? You have been managing severe PIH in your hospitals for 2 years, 3 years time. You will not make a mistake in that. So don't be concerned about anesthesia. Anesthesia is something that you know very well. You are very well versed in anesthesia. If you don't know anything, just close your eyes and think what you are going to do in the theater with that patient, and you will be able to say the right thing. You will not do anything wrong with your patient. So don't consider your practical aspect of what you have done in the last 2-3 years to the thing that is asked in the exam. They are not two different things. They are the same thing. You just need to be in a state of mind to be able to emote it properly and be able to justify what you are saying. All right. So that is the beauty of anesthesia. What is not in your hand is the part which you don't normally know. That is the PSM stuff. So the PSM part, the sterilization, the disinfection, the statistics, the biomedical waste management, if you don't read, you will always make a mistake. So read things that you are more likely to forget because they are not from your core understanding of anesthesia. All right. And there would be one definite question on CPR. It could be latest change in the 2020 update, adult versus pediatric CPR, image of an AED, types of defibrillation, cardiac arrest rhythms, or ECG. Then there is a cardiac arrest rhythm. Then what drugs do you use in CPR? So this is something which is standard format. Every OSCE, 20 stations they have to ask. They will have to divide it in 20 parts in anesthesia. And you very well know that there is an easy part of anesthesia everywhere. Now, what happens in your OSCE? You think that you will be able to answer 100% of 100%. So you are very anxious because what you see on the monitor is a set of 3 or 4 or 5 questions, isn't it? But remember, you don't have to think about answering everything. You have to make sure that whatever answer you write should be complete, because a complete answer will give you 1 mark. Isn't it? There are usually 4 to 5 marks. So a complete answer will give you 1 mark. But if you write half answers in every of them, half. So you have RCRI criteria. Suppose they ask you what are the 6 things in RCRI, and you are in a hurry because you want to read. There are 4 questions, and you only write 3, and you say, "Chalo, theek hai, 3 likh ke aage badhte hain." They might not award you any marks. That is because the examiner will look. They have an answer key. If you write 6, you get 2 marks. If you have written 3, there is nowhere written that you will get 1 mark, so they might not award you. So what is important is that every station, so you have got 20 stations, let's consider an average of 4 questions per station, because every OSCE has 5 marks. So let's say 4 stations, 4 questions. So that will make a total of 80 questions over 80 minutes. 80 questions, 80 minutes. So 1 minute to read the question, to analyze and write. So don't jump the line. Take 1 minute and answer completely. If the slide changes and you are not able to read the last question, that is fine. You just lose 1 or at max 2 marks. 1 or at max 2 marks. Your target in OSCE is to score 75 out of 100. How much do you want to score? 75 out of 100. You don't want to score 100 out of 100. You don't even want to target 100 out of 100. You want to only score 75 out of 100. That should be your mindset. When you know that you won't make mistakes or you will make mistakes in 25 questions, you become calmer. When you become calm, you read the question carefully so you don't have to reread the question and you write a complete answer. That is what is required in your OSCEs. Now let's break it down. If you score 70 to 75 marks in your OSCEs, which is 100 marks, then out of the total passing, that is 150, half of the job is done. You are already 70, 75. And this is sure shot because you are in control of this thing. The examiner's mood or the examiner's area or the examiner's hospital of practice has no bearing on how you do in your OSCEs, isn't it? That is the beauty of OSCE because OSCE may control is in your hand. It is not in the hands of the examiner. So you want to score maximum where you have control. So OSCE is your mainstay. How to prepare for OSCE? Just keep on reading. Just keep on reading. I told you the general format. There will be X-rays, there will be ECGs, there will be focus, there will be CPR, there will be anesthetic. So it is going to ask you questions from every aspect. So just keep flipping your notebooks. Just keep flipping the book, the notes that you have made, and you just keep reading them. There is nothing more than you need in an OSCE. Keep in your mind 1 minute for one answer. So you read, you analyze, and you write a complete answer in a legible handwriting. That is what is expected from you in an OSCE. That is what is expected from you. And I am assuring you, since you have cleared your DNB theory exam, you will be able to mark 70 to 75 parts of OSCE correctly. You take it in to take from me in writing. Aram se, if you keep a cool mind, you will get 70, 75 easily. Half of your job is done. Now, all you have to do is out of the rest of 200, you have to score just 75. 200 ka 50% is 100. 200 ka 37.5% is 75. That means even if you do very bad in your practicals, still vivas, still you will be able to pass. So your mainstay of passing your practical exam happens in the first 80 minutes of your exam. In the first 1.5 hours, you are either pass or you are now, you don't know. Okay? So keep your entire coolness, calmness, everything that you are preparing should be focused on your OSCEs. OSCEs have been introduced so that the over-reliance of your results on the examiner and their mood is lessened. Now, even when the examiner is completely adamant that I have to fail, that is the only condition when they will fail you. Otherwise, you tend to pass a lot. That is why you see a lot of anesthesia residents passing very easily in the exam. Okay? We have a good pass percentage. This is the first part. Any doubts in OSCE? Any doubts that you have in OSCE? And you can ask the doubts on, you can talk to me. You don't have to just hide and not, you can use your voice also. I feel much better. No questions? Shall I move ahead? Shall I move ahead? You can say yes, no, yaar. Kuch to bolo. You have to talk in your exams also, na? मेरे से बात कर लो.
Sir, what is the percentage of repetitions in OSCE? Like, do
Repetition,
they tend to repeat or will it be new every time?
repetitions in terms of questions.
Yes, sir. Question or topic per se.
Topics to always will get repeated now. You will always get an ECG, you will always get a chest X-ray, you will always get a USG image, you will always get a brachial plexus block, you will always get a regional block, you will always get a CPR question. Topics are standard. And if you see, all the topics are standard. When you will go for a viva also, you have 2 long cases, 4 short cases, all standard. When you go for a table also, everything is standard, isn't it? See, you have to understand the psyche of the examiner, and this is the next part that I want to discuss. Suppose the best way of actually, this is like a reverse engineering thing that you have to do. Suppose I put you in charge of passing students for practical exams or being the examiner. So close your eyes and tell me what would you think if I give you this great responsibility that now you are the person who is standing between a student and a practicing anesthetist. You are the one who is going to decide whether this person can go tomorrow and alone in a setup which doesn't really have too much in a periphery can give spinal to a patient for an LSCS. You are the one who is going to decide this power I have given it to you. So what would be your thought process? Anybody wants to weigh in? What would be your thought process? What would you do if you are in charge of assessing a student, and once you assess and you decide, okay, this student is now worthy of being called an anesthetist, then what would go in your mind? What would you look in that student? You tell me that. Anybody?
So common topics only.
Very good. That's a good start. Common topics. But is that the only thing that would be in your mind? That they should know common topics?
The person is giving safe anesthesia only. That should be the motive of the examiner to assess.
Absolutely perfect. Now you have thought of the exact thing. If you have been put in charge to pass a student, and after you pass, tomorrow they become an anesthetist who goes out in the society at large and give anesthesia, your only intention would be ye kisi ko maar na de. That person should not be unsafe so that a patient gets killed on the OT table, iatrogenic death, because the moral liability of that will lie somewhere to the examiner who has said, okay, I feel that this student is eligible to go out and start practicing. Just keep this thing in your mind. When you are sitting in your vivas, and you will have ample of vivas, you will have 2 long cases, you have 4 short cases, and you have 5 tables, 4 to 5 tables, isn't it? When you have so many places where you are going to talk to the 4 examiners who are going to come and take your exam, all they want to look at is whether you are safe anesthetist or not. So never say anything that is going to kill your patient. Now, the patient comes with mitral stenosis, mitral wall area is 1. And you say, nahi sir, main to spinal nahi karunga. The examiner will tell you, are you sure you want to do this in spinal? It's a very tight stenosis. Do you think would be safer? Yes, sir, in my institute, we do in spinal epidural only. That would tell that the student is reckless. The student doesn't have awareness that when you have such tight stenosis, then you would probably want to control everything and at least not cause sudden decrease in the SVR that can lead to failure. Right? You have an asthmatic patient, and you say कि नहीं सर मैं तो ट्यूब भी करूंगा, मैं तो स्कोलिंग भी दूंगा, मसल रिलैक्सेंट एट्राक्यूरियम भी दूंगा, मैं तो करूंगा सर, मेरे इंस्टीट्यूट में तो ये बताते हैं. So will that examiner feel confident that what you have said and what you are going to do out in the society at large is acceptable? No. So those are the reasons why what they seek for. So all they are going to do is that they are going to see whether you are safe anesthetist or not. Just keep that thing in your mind that when you are discussing your cases, you don't have to kill your patient on the table. You don't have to do anything that is going to harm your patient. There is no problem in giving general anesthesia if that saves the life of the patient. There is a hypotensive patient, shock, exploratory laparotomy, the blood is on the way, but the surgeon says you have to open up the patient because there is hemoperitoneum. You will not go for spinal anesthesia. You will say, I will start a vasopressor and I will immediately give a rapid sequence induction, and you will use little bit of propofol, little bit of ketamine, and you will give scoline and intubate, and then see how things goes. Then you will take lines and stuff like that. So remember, just don't kill a patient. If you don't kill a patient, there is no reason why the examiner should fail you. All right. So this is the general theme that I want to talk about. But let's come to the specifics now. So out of the 100 in OSCE, 70, 75 is done. Now you are fighting for the rest of 75. Again, think where you have more marks and where you have more control. So where do you think you have more marks and more control? What, according to you, in the viva part, viva has cases and table. Where do you think you have more marks? And it is more about control, less about marks, because you can't control everything. There are only few things that you can control.
The long cases.
Yes. The most important part of your viva is the long case. Look at the weightage. Out of the 200 marks, 100 marks are only on long cases. That means everything else, long case, you will get about, say, half an hour to 40 minutes to take. And per long case, the viva would be, say, 20 to 35 minutes. If you are very bad, then 35 minutes. If you are very good, 20 minutes. And yes, it is opposite. If you are very good, you answer everything fast, then the examiner lets you go in about 20 minutes. Whatever I want to know for this case, the person has told. If you are very bad, then the examiner will give you lots of chances. The examiner will keep asking you a lot of things. The examiner will keep pushing. Acha, you will do this, then what you will do that? Acha, you will do this, then what about that? So your viva is going to go for longer. That doesn't mean if your viva is going longer, that means you are not doing good. But approximately 20 to 35 minutes. So when you start taking cases in the morning, in the first 3 hours, the 100 mark viva is done. Everybody's 100 marks vivas are done. That is the beauty of it. You start at 8, by 9:30, bulk of your scoring is done in OSCEs, and by 12:30, your next 100 marks is done. So you start at 8, and by 12:30, that is before lunch, you are already in a state where you can say I'm passed or not. And this is, I'm telling you from my personal experience. When I went for my DNB practical exams, at lunch, everybody was pretty tensed, and I was in a very good center, GMC Chandigarh. And there the HOD, she called for pizzas for everybody for the lunch. They said, don't go out and try and find the place to eat. So we'll order pizzas for you, pizza and cold drink. So you all sit together and you have your meal. So everybody was very tensed and they were like, Hare Babre, Hare Babre, Hare Babre. And I was merrily eating my pizza. Why? Because I knew that time that I'm passed. I had my long cases. Then that time we had 4 long cases and then 4 short cases. And I knew that I am done because I gave very good long cases, because again, the long case is more about anesthesia and less about case taking. Remember, the people taking your exam are also anesthetists. You are also anesthetist. Very few teachers who are exceptional. Nobody is going to go into too much details of how you take a case. Nobody is interested in that. Nobody is interested in whether you know the Pollock's maneuver or you know the pelvic maneuver, and whether you can identify whether there is a systolic ejection murmur or there is a diastolic murmur or there is an ejection click. Nobody is interested in all those things. And most of the time we get post-operative patients. If there is a TURP patient, you will get a post-operative patient with a catheter who have undergone a TURP a day before. There is nothing much clinical that is going to be stressed upon. So what is the funda? Then you will say, sir, how to take the history. So you have the case formats. There is nothing different about the case taking. Any system, you go by history, you go by negative history, you go by past history, you go by family history, and you ask the relevant history. Then you move on to the general examination, which you have done innumerable number of times in the last 3 years of your DNB. The same thing you do TRP, BP, you do all the general examination, but a very important element is always do airway examination. And airway examination is the thing that you have to do in detail because you are an anesthetist. So irrespective of what the case is, airway examination will mention everything. It will mention mouth opening, it will mention inter-incisor distance, subluxation. You will have upper lip bite test. You will have thyromental distance, you will have sternomental distance, you will have range of motion. If you want, if you have time, you can write about Wilson score and everything. You can write about the condition of the teeth. You can write about any other factors. You can talk about obesity. You can talk about anteroposterior diameter of the chest. To all those things, that is going to tell you whether it is going to be an easy airway or difficult, because the examiner should not feel that, acha, case so you have taken like a medicine person, but you don't know the airway examination, because you are an anesthetist. For you, airway is the supreme priority. And then systemic examination, only relevant system and positive findings. So suppose you have a mitral stenosis patient. So cardiovascular is a relevant system, and your findings would be that there is a murmur. There is a murmur. What murmur? Sir, it appears like a diastolic murmur. What kind of diastolic murmur? If you are not able to delineate, just say, sir, I can only understand that there is a diastolic murmur. The examiner will ask you, okay, how did you identify it's a diastolic murmur? So you will say, sir, I kept listening to the sounds, and then there is a lub, and then there is a dub. So lub stands for systole, dub stands for diastole. So if you hear a murmur after the lub, it goes into the diastole, and after the dub, it goes into a systole. So systolic murmur and diastolic murmur. So the idea is you only say the thing that you can justify. Try to understand. If you can justify murmur, just say murmur. If you can justify diastolic murmur, say diastolic murmur. If you can justify mid-diastolic murmur, you say mid-diastolic. If you can justify mid-diastolic murmur with ejection clip, you say that. There are no brownie points for writing a perfect case, but actually not able to justify it, because the examiner will catch your bluff very easily. It is very easy for me to know just looking at your face that whether you are bluffing or not, because I have been in that position for a very long time. I know how students bluff, what can be found out, what cannot be found out. So don't treat your examiners as fools. Rather, always stand there and be very subdued. Always make them believe that you are ready to understand that you have made a mistake. So sorry is the word that you are looking for. If at all you say something that you can't justify, don't go on to create new strategies and new concepts. Just say, sorry, sir, I thought that I understood mid-diastolic murmur, but I'm not able to do it right now. Do it right now. Be an open-ended statement. That is something that is going to help you a lot. Be true. Because, again, the psyche of the examiner. If the examiner catches you lying in the exam, then what the examiner will think is not that you are trying to save your skin. The examiner will think that if you can lie to that examiner in the exam, you can lie to your seniors in the OT. So you are not a safe anesthetist. If you can lie right now under so much pressure, you can lie otherwise also कि हाँ सर मैंने तो मेफेंटरमीन दिया था, हाँ सर मैंने तो ondansetron दिया था, yes sir I took the history, the patient was NDM. So their thought process is that this person cannot be relied on. So never ever bluff in the exam. If you know something, talk about it. If you don't know something, don't bluff. Just say, sorry, sir, I don't know. There are no problems if you say sorry. No problems if you say sorry. Nobody is supposed to know everything about anesthesia at the level of post-graduation, especially in a viva. So don't get into this thought process that you will have to know everything and then only you will be able to pass the exam. No. The passing criteria for this exam is 50%. That means the examiners have also set the criteria that out of everything that we are going to ask you, even if you know 50%, then we are okay. We are okay to make you an anesthetist to go and practice, even if you know 50%. So their criteria is also very less strict. It is also very simple कि यार 50% आना चाहिए. All right. So again, you will have two parts to your viva. You will have the cases and you will have the table. Let's talk about cases. The cases are long cases and short cases, but what I have known and I have seen and I have understood is they don't do much distinction. They want to finish the viva part fast. So they tell you, okay, go into the ward. They will distribute you chits. Most of the time it is chit system. Whatever number comes, there are patients in the ward and they might tell you that this is a long case, this is a short case, or they might just tell you go and take the number of cases in your chit. You go, you take history and everything. you immediately write it down, and when you are coming back, consider that you are the first person to go for the viva, start memorizing it. A very important aspect is, if it would be better if you don't see the paper when you are describing a case. That has a very good impact in the exam. So try to memorize all the positive findings in your case. It doesn't have to be an elaborate case, but whatever you say has to be true, has to be something that you found out. It is not something you just write down and kind of bluff it out. So remember, just be true to the case. Just write what you are able to find out. In half an hour, in 40 minutes, you can't find out everything about the patient. Even your examiners understand this point. All right. Are you guys with me? There's absolute silence from your end.
Yes, sir.
Yeah, perfect. So
Yes,
you take, perfect. So you take the cases, you come back. Try to memorize everything that you have written in your case. Case formats are everywhere. You don't have to sweat too much on the case format. Important is primary history in the patient language. First, the details of the patient, primary history, negative history. You will know what the patient is. It's not very difficult. If you are not able to know, there will be people to help you. Even if then you are not able to know, then just try to find out from the patient what system he has a problem, and then present your paper, present your case accordingly. Try to finish off the case part as early as possible so that you can then put your thought process on the viva part. The viva will be on the anesthetic management of that condition, because the examiner ultimately wants you to know anesthesia. You are going to become an anesthetist. The person taking the viva is also an anesthetist. So just focus on the anesthesia part. Do not talk too much to other people in the exam. Don't be too hassled. Don't think you are going to learn too much in the exam if you are going to ask the people, or suppose you have a friend and now you are a part of this group. So you might actually go and interact. Okay, we were on the Zoom call and we are a part of the search group, so let's talk. No. Try to focus on your energy in your case. Try to memorize everything. Try to find that what all questions the examiner will be asked. And these are the questions which are asked in theory. Suppose you have a patient of, say, 75-year-old patient with TURP, post-operative day 1. He has a catheter. The urine in the catheter is red, and there is a what you can say, the flushing going on, right? So you take the case, the patient tells the history, there is general examination, there is systemic examination, all these things, and then you are sitting there, then what all things the examiner will ask? The examiner will ask the geriatric physiology. The examiner will ask about history of diabetes. If there is a history of diabetes, then whether you identified the palm print sign to assess the difficulty of airway, and whether you knew that these patients have these joint problems which makes intubation very difficult. Then whether any spine or back problem, and then there is fibrosis of the spine and the ligament, so spinal becomes very difficult. Then what is your criteria of putting the level T10 for TURP? Because you want to rule out bladder perforation during the surgery. Then the rule of 6, where what all things you have to take care of, and in geriatric, what are the things that can happen in terms of hemodynamics after the spinal and the autonomic dysfunction. That all those things which you read for theory are the things that are going to be asked in your practical. Unless until the examiner deviates from the topic themselves. So then be ready. Then again, always take your time. Suppose I am the student and you are the examiner, and you ask me, can you describe the anesthetic management of a patient posted for TURBT? The patient is TURP, but the examiner has asked you TURBT, transurethral resection of bladder tumor. Now you are suddenly caught off guard. So don't start by, sir, in TURBT, sir, obturator nerve block. Because you know TURBT, there will be a tumor which when resected, then there can be a obturator nerve stimulation which can cause knee jerk, which can cause damage to the patient, isn't it? So आप क्या करोगे? Direct obturator nerve block बोल दोगे. That is not a coherent answer. So when the examiner asks you, you take 5 seconds. Right. Sir, in TURBT, which is transurethral resection of bladder tumor, apart from the routine considerations of the patient being a geriatric patient and the diagnosis of cancer, the biggest anesthetic challenge is that if the tumor is on the lateral wall And if the surgeon is doing extensive resection of the tumor, then because of direct stimulation of the obturator nerve, there can be a knee jerk which can damage the surgeon, which can cause muscle damage to the or injury to the patient. Also, it can cause the resectoscope to pass through the bladder, causing intraperitoneal bladder perforation. So in that case, either we will go for a general anesthesia with muscle relaxation or spinal anesthesia with an obturator nerve block. Now stop here. You know what is obturator nerve block. You have read it. You know the landmarks. You know how to give it. You know when to give it. Don't say it immediately. Wait. It is an open-ended answer. Now, the moment you stop at that, if I am the examiner, my next question would be, can you tell me what is and how you do obturator nerve block? So then you say, okay, sir. So for obturator nerve block, the course is this. We can either use a sonography machine. You can look at this, or we can use a PNS. You can go palpate the pubic tubercle, go 1 centimeter medial, 1 centimeter lateral and inferior. We will hit the bone, we'll come back, we'll see the dancing of the knee, and we will inject 10 ml of 0.5% bupivacaine or 10 ml of 2% lignocaine plus adrenaline, depending on the local anesthetic of your choice. This is how your answer should be. It should be coherent, and every answer should always start with the anesthetic concerns, preoperative assessment, preoperative preparation, intraoperative, the method by which you do intraoperative practice, and then postoperative concerns and their management. Irrespective of which case you are taking, irrespective of how you are taking, you are always supposed to structure your answer in this way. All right. Am I being clear about this?
Yes, sir.
Okay. So this is about the viva part. This is the viva of your cases. Now, a lot of you have these questions in your mind, ki, sir, will we be able to get time to take a detailed history? Will we be able to do all the systemic things, sir, obs, pediatric? So the answer is very simple. Whatever time is being allotted to you, whatever you can do in that time is sufficient. Some centers, they will give you 2 hours to take the case. If you have more time, you go more in deep. Some center will give you 30-35 minutes per case and will say, fatafat isko finish karo, come for viva. We are more interested in talking to you rather you taking the case. Understood? That depends on institute to institute. That you will know at the beginning when you reach there. All right. Now comes the last part of the discussion. That is your table viva, which by now you must have realized is the least important thing in your entire practical exams, for which you sweat the most, isn't it? It is least important in terms of weightage. But everything is a pattern in table viva. You have usually 4 or 5 table vivas. 4, one would be anesthesia machine, vaporizers, airways. One would be chest X-ray, flow volume loops, PFTs, ABGs. One would be case scenarios, and one would be all the resuscitation equipments and all the drugs. This is a general understanding of your vivas. And one in DNB, you will always get a 5th head, which is communication skills and your practicals and your the thesis. Yes, communication skills and thesis. All right. So try to understand this thing, that you will have 5 heads, you have 60 marks. So that is 12 marks per head. So no particular head can pass you or fail you. If you do very good, they might give you 8 marks. If you do very bad, they might give you 4 marks. There is a difference of just 4 marks. It is not something that is going to change your life. So by the time you reach your tables, you should be very relaxed. Now, how to prepare for the tables? So you know the setup. So prepare one best for everything. So suppose you sit, and most of the time what I've noticed is the examiners, they give you a choice. Pick up a drug, pick up a circuit, pick up an instrument, pick up a tube, pick up a ABG, pick up an X-ray, pick up an ECG, pick up a scenario. Now, of these ECG and scenarios, something which prima facie you won't be able to look, understand, and then pick up. So you might just pick up whatever comes. But rest of the things, the moment you go and sit in front of the examiner, you start scanning where that drug is. Like I prepared etomidate. Why? Very specific, nobody picks it, very specific, limited information. Nothing much can go wrong with etomidate. In muscle relaxants, I prepared rocuronium. In reversal, I prepared neostigmine. In vasopressors, I prepared noradrenaline, which the examiner wants you to know. In airways, I prepared DLT because you can talk a lot about DLT, so you consume a lot of time talking the right things. In LMAs, I kept in my mind that I'm going to pick up SLIPA. Why? SLIPA is difficult to diagnose, not use, not much information, so very, very easily you'll be able to talk. So for every table, every entity, pick one perfect thing which you have prepared, and you structure your answer in a way that suppose you are lucky enough that the examiner tells you pick up this thing, then all you have to do is that find that drug and pretend as if you have just picked up by chance. It should not appear as if you knew that you want to pick etomidate. Then you look at the drug and then you pretend as if you're thinking about it right now, and then you say, okay, sir, this is etomidate, which is an IV induction agent, which is an imidazole derivative. Its mechanism of action is GABA agonism, and that is why it depresses the brain activity, and it is an excellent IV induction agent which causes pain on injection. Its MCT, LCT versions cause lesser pain on injection. It has also a water-soluble variant which has no pain on injection. The pharmacokinetics are the absorption of the drug happens intravenously. It cannot be taken orally or intramuscularly, and there is redistribution in the blood. It has an onset of action of about 60 to 90 seconds. That is about 1 arm brain circulation time, and its duration of action is about 10 to 12 minutes. In terms of metabolism, it is metabolized by plasma esterases enzyme, so it has no organ dependent metabolism, so doesn't stay. So by the time you reach here and you have not even started talking about the use, the examiner is already impressed that you are describing a drug the way it should be described. Then the examiner might cut you and say, okay, leave that drug, pick up another drug, but your impression is made. Now you have answered the first question correctly. Now whatever drug comes your way, you always start with this way. And remember, in 2 minutes, you can't possibly think of answering everything. Even the examiner knows you can't answer everything. So you only answer the things that you remember, which are on top of your head and which are the relevant things. Like in etomidate, I would say cardiostability, I will say 11 beta hydroxylase inhibition causing dose-dependent adrenocortical dysfunction. That is why not to be given as an infusion. Two very important things, pain and yes, highest incidence of myoclonus and nystagmus and involuntary muscle movement, which can become a problem later on. So if you don't have time, if the examiner rushes you, tells you to answer 3 points, 4 points, it should be top of your mind. So for every single table, you prepare 1 or 2 perfect answers. So when given the choice of picking, you pick that particular thing. And for that, you have to be smart enough that when you are entering and you are sitting and you are saying good morning, one of your eye is just scanning on the table where what is kept. Because everything is arranged so that it will become easy for them also. All the tubes will be here, all the LMS would be here, all the airways would be here, all the other things would be here, connector would be here, Rambu would be here, machine would be at the back. The examiner might say, okay, go to that part of the machine. Can you tell me what valve is this? Can you tell me what is the function of this part, right? So try to understand these things, that you can always beat the examiner by having situation awareness. And that is why I started this meeting with this thought process that you don't have to be best at everything to be able to pass your exam. So don't think that in entirety, those 10 hours that you're going to spend giving your viva, everything is just about your knowledge. No, sometimes it is just about your smartness, how you make your examiner feel. All right. Last comes the part which is a must for you, that is the communication skills part. And there they will also ask you about your thesis. Now, what are they going to ask you about your thesis? The first thing that they are going to start is the title. You should remember every single word of the title of your thesis. You cannot make a mistake in your thesis. That is the thing that you are supposed to do for 3 years. You have written it yourself and you have submitted it to DNB. So don't make a mistake in your thesis. So your title, what are your aims and objectives? What are your final conclusion points? How did you calculate the sample size? And the answer to this question is no, you didn't give it to the biostatistician who told you that you have to do 250 cases. There is a formula to calculate the sample size, which is based on a previous study. So you talk about that study, you take the beta value, then you put it in the formula. Even if you don't remember the formula, that is fine, but you can always say that I used a sample size calculator on SSPE, and then the sample size that came was 250 cases or 50 cases or 100 cases, whatever was your sample size, divided into two parts, which were randomly selected and double-blinded. Then comes the communication skills part. Now, communication skills is very easy because there are only 4 or 5 scenarios. What are the 4 or 5 scenarios? Breaking the bad news. Somebody was taken in the operation theater and had a sudden massive cardiac arrest and succumbed. If there is a mob in your casualty or outside your OT, how would you handle it? How would you counsel a patient who has just received the news of a terminal illness or a cancer? And in general, what are the points that you will want to put forward while taking a written informed consent? There are nothing more than this. There are only 5 or 6 scenarios. You can just Google them up. I have already discussed all these scenarios in my course. So you have the PDF which you can just go through. You have to say words like spikes protocol. You have to say bricks protocol. You have to say that I'm going to use the spikes protocol and remember what are the things in spikes protocol. And again, this is a very standard question that would be asked last in the viva. And by that time, you are mentally exhausted, I know. So just be precise and just make sure that you deliver whatever you have read. And these are the general things that you have to take care of. Okay. Last point, the messages that I got. Sir, what case will be kept there? Do you know somebody in that institute? I have no idea what is kept in that institute. Listen, one, all exam centers are in premium institutes. Premium institutes have all the cases. If they don't have a case, they will print a sheet regarding that case and give you that sheet. That is also possible. So don't leave any stone unturned. Don't think that this particular case will not be asked or that particular case will not be asked, or pediatric would not be asked, or geriatric would not be asked, or pregnancy would not be asked, or eye would not be asked, or ENT would not be asked, or NORA would not. Everything and anything that you have read can be asked in your exam. 2, there is no point in trying to control the things which are beyond your control. What is in your control? You have got 5 days with you. Sit, just keep flipping books. Focus more on the part of OSCE and the long cases. Focus less on drugs and vivas because their weightage is very less. You anyway know pertinent points about everything. Whatever book you are referring to, whether you are referring to Baheti or you are referring to Tata ARC or Kaushik Jyotirnath, just keep flipping your pages. Don't go into the details of anything because the examiner is not going to give you chances to describe that detail. In theory, when you have time, you can write something in detail. But in practical, you don't have time. The moment you start answering, the examiner will change the question because he will realize कि तुझे आता है. अगर तुझे आता है, तो I'll ask you something जो तुझे नहीं आता है. That is how the viva ends. The viva always ends in you saying, sorry, sir, I don't know. Because the viva can never end with you saying something that you know and the examiner will be like, okay, thank you, go. The viva will always end at a point where you will say, sorry, sir, this is something that I don't know. So don't think you will be able to emote everything and say everything. So just superficially touch everything so that you don't make a mistake. And you have to keep strategizing every part of your exam. You are pass in your practical exam in the first 4 hours. You have to believe it. And you have to work towards passing in the first 4 hours. Once your OSCE and long cases are done nicely, nobody can fail you. And trust me this thing, nobody can fail you. After that, when you know that nobody can fail you, you will be very relaxed. And you also know when you are relaxed, your performance becomes better. All right. So this is what I wanted to discuss with you all. This is the part that is an amalgamation of my experience over the years talking to students, giving both the vivas myself. If you have any more doubts, then feel free to ask.